As these talks are pre-recorded, I have no idea what Rich just said, but I am sure that being a Harvard man, a gentleman, and a friend, that he exhibited the utmost in decorum and HIPAA compliance. And besides, I know where you live. I appreciate the honor and privilege of serving as your president over the past 2 years. A unique opportunity to give back to the organization that has been so instrumental in the formation of my career. Faced with the last-minute cancellation of the 2020 meeting, I was humbled by the request of the council to continue my term for an additional year. I thank each of them for accepting my reciprocal offer to continue their duties as well. The pandemic touched each of us with personal and professional upheaval. The impulse is to retreat into our own lives. I am humbled by the outpouring and dedication of our entire membership that they have shown to this organization. The AES has come out stronger because of each of you. Before I begin my formal presentation, I need to recognize those who have supported me and have the greatest influence on my life. I would first like to thank my wife, Dr. Holly Miller, for her endless support and motivation throughout my career. An internist by training, she's devoted her professional career to leveraging the electronic medical record to improve the quality of health care. She has more energy and mitochondria than anyone I know, a devoted mother and tireless gardener, and has the unenviable task of keeping me in line. My 5 children, with 1 spouse, are an endless source of pride and joy as they have grown to adults and found their place in the world, only occasionally causing me to age prematurely. My parents, Marvin and Eleanor, taught me curiosity and the wonders of scientific investigation from a young age. They met at Berkeley, California, both studying in Chekhov's lab of the Wolff-Chaikoff effect. Growing up in Dallas, lacking babysitters, many school holidays and weekends were spent in their labs. My mother, now 91, was a pituitary cell biologist. As a child, the first operation I ever saw was her performing a bilateral adrenalectomy on rats. By subsequently studying the pituitary under the electron microscope, she was able to identify the cell type that changed and hence secretes ACTH. At some level, I could understand her work. It was very visual. She would show me pictures of cells and their organelles and tell me stories of how the cells worked. My father was an endocrinologist, studying diabetes and cholesterol metabolism. He worked out the metabolic pathway of cholesterol synthesis, identifying HMG-CoA reductase as its rate-limiting step, the target now used by statins. As a child, the science I did not understand, squiggly lines coming off a gas chromatograph. Exciting were the animals he used to map out these pathways. Yes, there were rats, but also sharks, frogs, iguanas, baboons. Unbeknownst to me at the time, all to be injected with radioactivity and meet a swift end. But I did absorb the excitement he had in doing experiments, and in particular discussing results with his fellows who would go on to become editors of Harrison's Textbook of Medicine, department chairs, and Nobel laureates. This was clearly a unique and rarefied environment to grow up in, and you wonder why I pursued the career that I did. Orlo Clark served as my mentor during residency, fellowship, and 10 years on faculty at UCSF. For a decade, we shared clinic and OR days. What an honor to be exposed to his greatness on a daily basis. A true surgeon-scientist, master technician, gentleman, and friend. Words cannot express the impact he has had on my career, and he remains with me every day. Thank you. I would like to share with you today some of my personal perspectives on endocrine surgery, both as an established surgical specialty as well as our professional organization, the American Association of Endocrine Surgeons. To put things in perspective, we have many great accomplishments. We have evolved from a clinical interest within general surgery, a hobby I like to call it, to a mature specialty. For many of us, our dominant or exclusive practice is in endocrine surgery, and there are now accredited fellowship training pathways to get there. Specialization has allowed for clinical and scientific advancement with many new insights into the underlying disease processes and applying the right procedure to the right patient. There has been clear demonstration that high-volume surgeons have better outcomes. Before I expand on these points further, I want to warn you in advance that the latter part of my talk is designed to move you out of your comfort zone and present you with future challenges that, as an organization and profession, we will be faced with. The world, as well as the science and practice of surgery, will continue to change. We will be held to a higher standard, both in terms of how we train those who want to enter our field and to our patients in terms of the quality of care we provide and in evaluating new technologies. When I joined the AES, it was a much smaller organization. Everyone knew everyone else. Only a handful of larger institutions had more than one individual practicing endocrine surgery. Many combined their practice with breast surgery, surgical oncology, or general surgery. The main focus of meetings in those days was to present and discuss scientific papers. Our organization has greatly expanded in its role. The key areas of growth have been in service to our members and service to our patients. On a superficial level, this can be quantified by the sheer increase in the number of committees and task forces. Pry open the lid, and more impressive is the tremendous number of accomplishments and contributions to our organization. What is the key to this success? You, our membership. Historically, committee members were appointed by leadership. The more recent self-nomination process drove home to me the talent, depth, and eagerness to contribute to our organization. Creative ideas have spawned new projects and initiatives. Our members in training have benefited from the oversight provided by the Fellowship Committee as well as the Fellowship Accreditation Committee that set standards for training programs. Our members benefit from the work of the Career and Leadership Development Committee to help guide and advise members, particularly early in their careers. Our Education Committee serves us during and after training. The Research Committee provides precious seed money for new projects. Both members and patients benefit from the Endocrine Surgery Identity Committee that, among other things, has provided name recognition to the somewhat obscure term endocrine surgery. Our website and Information Technology Committee has expanded our internet and, importantly these days, social media presence. We have reached out to multiple patient groups through the Patient Advocacy Committee, making them aware of our organization as well as providing educational resources. Our quality registry continues to expand its focus and has fostered multi-institutional collaboration. The Guidelines and Emerging Therapeutics Committee produce state-of-the-art papers promoting a best practice and giving us guidance on the use of new technologies. Our former Community Practice Committee has evolved into the Clinical Practice Community, a subtle but important name change. They advance the logistics of practice, such as coding and reimbursement, that applies to us all. Given the complexity of our organization, an ethics committee was started to make sure that we abide by the highest of standards. I am proud of the newly formed Diversity, Equity, and Inclusion Committee, who will ensure that all are welcomed and will thrive in our organization. Historically, general surgery residents who expressed an interest in endocrine surgery could gain additional exposure during residency as part of their research years, or in some cases an ad hoc apprenticeship following training. I was fortunate to have a string of residents come spend an extra year of training with me. In an attempt to legitimize this, at least locally, I registered the fellowship through our graduate medical education department, so at least they would receive a fancy certificate at the end of training. It became apparent that several institutions had a similar arrangement, and others had the desire to take on trainees. 15 years ago, I approached the council with the idea of starting a matching process for endocrine surgery fellowships. The motivations for this were several-fold. This was the most equitable way to align applicants with places they would want to train. Previously, this was purely a first-come, first-served process. The deeper motivation was to further legitimize the field of endocrine surgery as a distinct specialty. At that time, we were beginning to understand volume outcomes relationships, with the point being driven home when seeing a patient referred to our practice with a bad outcome that could have been avoided. Our field was also advancing quickly, hence requiring additional specialized training. There were changes in our understanding of the biology of thyroid cancer, the interpretation of fine needle aspirations, the extent of surgery required, and the optimal patient follow-up. From a technical point of view, surgeon-performed ultrasound was relatively new. Energy sources were now more routinely used to perform thyroid surgery, and laparoscopic and subsequent robotic technologies were evolving. But potential concerns were raised as well. Our roots in a broad general surgery training were already being fragmented by colorectal and breast surgery evolving as distinct subspecialties. Integrated surgical programs, bypassing initial general surgery training, were on the horizon in plastics, vascular, and cardiothoracic surgery. Despite this, the Council approved the formation of a match process for endocrine surgery fellowships. Although not my intention, I was instantly tasked with taking on that responsibility. A word to the wise about coming up with any bright ideas, you will instantly be placed in charge. Parenthetically, similar slips of the tongue landed me the job as a general surgery residency program director for 14 years. Back then, the matching process for the 13 inaugural programs was done on paper, as there was no commercially available computer program. Urban legend says that I did this on my kitchen table, somewhat more picturesque than the reality of this being done in my office. Our organization has advanced well beyond these early days. We now have goals and objectives for the teaching of our fellows, and there is now an accreditation process to ensure high standards for new and existing programs. So what are the future challenges in the education of our endocrine surgery fellows? We are fortunate to recruit the best and the brightest who excel clinically, technically, and academically. I do my best to treat each of my fellows as professional athletes. No matter how good they are in any of these areas, I push and challenge them to do better. My goal during the course of the year is to start with a general surgery chief resident and end with an independent practitioner. But there are challenges to this. As you know, CMS funds a large portion of graduate medical education with the intention that residents will provide care to underserved populations. Turning the page, however, you will find multiple regulations that limit any type of independent healthcare delivery. Despite their medical degree, they are treated as adolescents, requiring parental supervision and sign-off for all of their activities. As opposed to being seen as a more junior member of the healthcare team, they are regarded as students by patients, insurers, and regulators. I'm not saying we go back to the good old days when I was a resident, typically on call and awake for the entire weekend. You checked in with your attending on Monday morning to let them know who had been admitted and operated on. Obviously, this past training allowed for clinical and operative independence. However, any lapses in this independent clinical decision-making were brutally obvious by the next Morbidity and Mortality Conference. In some ways, we are fortunate that our fellowships are not under the ACGME. Such fellows are technically residents and under their same regulatory constraints. By bringing on our fellows as junior faculty, for example, we then have a pathway for greater independence. So how do we thread this needle? We need to create an environment that will best foster lifelong learners who are equipped to assess new literature and appropriately adopt changes into our rapidly advancing field. I feel that fellows are best served by being in a solid academic environment with multidisciplinary care and faculty who demonstrate competence as educators. To break this down somewhat, the academic environment allows for critical review of studies that guide our current and future practice pattern. It creates a varied exposure and ability to critically discuss the science guiding our clinical care. In an academic environment, exposure to residents and medical students allows the fellows themselves to mature as educators. Multidisciplinary care exposes fellows to the perspectives of other medical specialties and the importance of a team-based approach to care. Multidisciplinary conferences and tumor boards reinforce this. We also must demonstrate that our faculty show competency as professional educators to promote optimal learning. We have moved beyond the apprentice model in medical education. An active understanding of competency-based assessment, communication skills, and implicit bias training is essential for the modern educator. Our organization is actively working to meet these future challenges. A project on entrustable professional activities will provide a pathway to ensure independent clinical skills at the completion of training. Raising the bar on our current fellowship accreditation standards will ensure an optimum environment for training and maturations. So what are the challenges I'm asking of you? We need the best to pursue a career in endocrine surgery. Seek out a bright, motivated, and diverse group of trainees and infect them with your passion for what you do. We must challenge ourselves to be at the top of our game as professional educators. This sometimes requires learning new tools, active engagement, and pushing our trainees to be the best they can be. We need to restructure our training programs to guarantee that when fellows are pushed out of the nest at the end of training, they will fly. But that is not the end. I challenge our senior members to mentor those rising within our organization so that they too meet their full potential. For the last section of my talk, I want to focus on new technological development. Let's go back to 1990, when I just finished my residency and laparoscopic cholecystectomy was in its infancy. Having been developed in the private sector, there was immediate skepticism and pushback on the part of academia. There was rapid recognition of the advantages of a laparoscopic approach on reducing postoperative pain, earlier return of bowel function, and shorter hospitalization. Appropriate concern was raised about the higher incidence of common bile duct injury with potential life-threatening consequences. Gallbladder perforation with spillage of bile and stones was frequent. Open cholecystectomy had been performed with a top-down approach, with the fundus and body of the gallbladder initially dissected from the liver, leaving the cystic duct and artery on a clearly defined pedicle. Surgeons were unfamiliar with dissecting the triangle of Callot early in the case, as current teaching to identify the critical view of these structures had not been developed. The basics of laparoscopy were novel as well. Many learned for the first time the foreign ergonomics that moving your hand upward moves the instrument down. The concept of viewing a two-dimensional screen to operate on a three-dimensional world was novel. The video systems were primitive, and I often compare them to images of Neil Armstrong's first steps on the moon. Ratcheted graspers did not exist, so we had digital nerve palsies from squeezing the instruments closed for hours. Surgeons new to laparoscopy would often come back from only a weekend course to do their first case. So how was it possible to recruit patients to a new and unproven technology? They were beating down the door for the latest and greatest in medical advancement. In a stroke of marketing genius, this was sold as a laser cholecystectomy. The kernel of truth is that some early adopters used a laser fiber as a thermal dissecting instrument. This was quickly abandoned, as it would slice open the gallbladder and any other structure it touched. Patients did not understand the word laparoscopic, so laser cholecystectomy was a perfect marketing term to seduce patients into thinking they were getting the future of medicine. To digress for a minute, we continue to this day to market our operations with somewhat misleading terms. When we use the term robotic surgery, patients think of R2-D2 standing beside us at the console guiding our hands. We would get a skeptical look from our patients if we told the patient they were being done using a remote manipulating instrument with articulating arms. We offer patients a minimally invasive parathyroidectomy as opposed to the traditional old-fashioned approach. Which would you choose? Instead, try the thought experiment of offering your patient an incomplete parathyroid exploration versus a comprehensive parathyroid exploration. Which would you choose? My point is that the words we use have the ability to influence a patient's decision-making. In offering a new technology to a patient, our duty in the consent process is to allow the patient to make a fully informed decision. I would argue that the terms we choose to describe our procedures should be objective and free from any perceived bias. The early laparoscopic era was one of great excitement. In service to our patients, it was clearly recognized that these advances could revolutionize surgery. The motivation behind many of these advances may not have been so laudable. There was tremendous ego and name recognition behind being the first to perform a new operation or develop a new technique. As a techie, it was exciting for me to be involved with new product development, some of which came to fruition and many fizzled. The disruptive technology of laparoscopic surgery quickly overtook open procedures in numerous specialties. These changes swept into clinical practice before more stringent hospital credentialing, IRB, and regulatory bodies could have slowed it. There was essentially no external regulation in taking on new procedures. In wanting to do a laparoscopic adrenalectomy for the first time, there was no specific credentialing or constraint. The justification in our minds is that we were doing the exact same operation, only modifying the approach. A half-truth at best. As with many laparoscopic procedures early in the learning curve, these were done as two attending cases. Yes, a step towards responsibility. I had the pleasure to do all our early adrenalectomies with my colleague and friend Kwan Du. In the interest of safety, having someone to bounce ideas off of and working with someone you felt comfortable with made sense. In reality, I wonder at times whether this allowed us to incorrectly convince one another that it was safe to cut into some vital structure. In preparation for our first case, we discussed in detail trocar placement and steps of the operation. A training video was reviewed multiple times. As is often done, a proctor with prior experience was scheduled to attend. Canceling his trip at the last minute, we reviewed the training videotape in the operating room just before the patient was wheeled in and proceeded. Through either careful preparation or luck, all went well. That was the pioneering spirit of the day, and guilty as charged. Was this the mark of innovation or reckless irresponsibility? In that era, small adrenal glands were often removed through an open posterior approach, made possible by excision of the 11th rib to gain access, a procedure most of you never had the privilege to perform. There was speculation that a similar laparoscopic approach could be applied, but challenged by the fact there was no obvious working space to gain access to the adrenal. I had been invited to a conference in Istanbul, Turkey. Through absolute coincidence, a colleague mentioned that a professor at his university, Dr. Selçuk Merjan, had actually performed several of these procedures. I accepted the invitation to scrub in on his 8th case. This was prior to any type of outcome data or a subsequent presentation of the technique at our 1995 meeting and publication in Surgery. Returning to San Francisco, we quickly lined up a patient for the procedure. Was this the mark of innovation or reckless irresponsibility? Many new and relatively untested devices were appearing in the operating room. The FDA regulates new devices in interesting ways. To oversimplify, if a device is truly novel, then it must go through a rigid investigational device protocol. The FDA carefully reviews the study design, patient enrollment criteria, and strict data collection requirements. Having been involved in such studies, I can attest to the rigid external oversight and monitoring that occurs for all phases of the study. Transcatheter aortic valve replacement, TAVR, is a recent example where I think this was done well. There was obviously a high-stakes device where technical errors in positioning or failure of the device itself could have instant and disastrous consequences. The device had the potential to avoid the morbidity of median sternotomy and cardiopulmonary bypass. Multiple centers participated with careful training in the procedure and strict adherence to the protocol. This led to rapid approval of the device with wide clinical adoption. Many devices go through what is called a 510(k) approval process. This is much more rapid and requires no human testing prior to being placed on the market. So how can this happen? The manufacturer is required to demonstrate that the new product is substantially equivalent to, or as the FDA uses the term, predicated upon, an existing device that has already been validated. For example, minimal modification of a stapling device or the addition of smoke evacuation tubing to an existing cautery pencil, this makes sense. In other situations, I find it a bit of a stretch of the imagination. I will impugn myself with another case in point. An engineer, whom I had done laparoscopic ultrasound development work with, called me to let me know he had moved to a new company. They were developing a device for the thermal destruction of prostate tumors using radiofrequency energy, a fancy term for the bovie. I told him I had little interest in the prostate, but saw potential treatment for liver. At that time, local treatment of liver tumors was done with cryoablation. A large probe was placed into the lesion and 2 lengthy freeze-thaw cycles were performed. With expansion of the ice ball, the surface of the liver, particularly when cirrhotic, would crack. A patient already hypothermic from a laparotomy would become more hypothermic. A patient who was already coagulopathic upon thawing of the ice ball would go into DIC from the acute release of cellular debris into the vasculature. So then I went to work. Extensive time was spent in the animal laboratory modifying the device itself and determining the appropriate power and time settings to create reproducible zones of ablation. How this device got 510K approval through the FDA is still somewhat of a mystery to me. Yes, there were devices with protruding prongs that used electrical energy for fulguration. None were widely used and for very different applications. The other interesting trick is that the devices may be approved for more general application before being allowed to be marketed for a more specific purpose. In these cases, early devices got FDA approval for soft tissue ablation. In this case, the soft tissue was normal pig liver. The company could in no way market the device with any statements relating to treating cancer or any specific organ. It is up to the discretion of the user to determine which soft tissue to ablate. This was also an era when it was thought dangerous to approach any cancer laparoscopically. Laparoscopic colectomy for colon cancer was a case in point. Early on, tumors were grossly fractured, resulting in carcinomatosis, and withdrawn without specimen retrieval bags, resulting in port site recurrence. There was also resistance from academia, who appropriately claimed validation studies were lacking, but at the same time felt their practices threatened as they had not yet learned advanced laparoscopic skills. There was even speculation that the carbon dioxide atmosphere within the abdominal cavity in some ways promoted tumor growth, a theory that was obviously disproved. I was fortunate in having access to early laparoscopic ultrasound equipment, as well as experience in performing ultrasound-guided liver biopsies. It was not an enormous stretch to use the same technique for the placement of these early ablation catheters. The first patient treated had a pancreatic islet cell cancer that had metastasized to the liver. The first series of patients was reported at these meetings in 1997 and described the technique and initial outcome of 6 patients with metastatic neuroendocrine tumor to the liver. Was this the mark of innovation or reckless irresponsibility? For this technology to be accepted by the more skeptical surgical oncology community, in particular for the treatment of colorectal metastases, a much more rigid approach would need to be applied. A prospective study was approved under the IRB with extensive data collection. There was a dedicated research coordinator to ensure proper recruitment and compliance with long-term follow-up. Anticipating external criticism, particular attention was paid to choosing appropriate outcomes to monitor. In particular, local recurrence, that is, failure to completely ablate the lesion, was monitored at 3 months intervals and judged by radiologists not involved in the study. To maintain objectivity, I refrained from any paid consulting agreements. Jumping ahead, these studies were ultimately used to approach the FDA to obtain a specific indication to treat liver tumors. In order to facilitate the adoption, AMA was approached for the 2-step process of first obtaining a CPT code and subsequent assignment of an RVU for the procedure. But those were the good old days. Although, at least for now, FDA regulations for new devices remain similar, we are, however, being held to a higher standard by our patients, our institutions, and our payers. With some significant and well-publicized failures of new technology, patients have become more skeptical of new devices and procedures. The Netflix documentary, The Bleeding Edge, examines potential hazards of new technology if rapidly pushed onto market by manufacturers and overzealously adopted by surgeons. Case in point are metal-on-metal hip implants, initially thought more durable than metal and plastic implants. Not appreciated was that the metal grinding on metal caused cobalt and chromium to be released with local and systemic ailments, including mental status changes. The Assure device was thought to be an easier and minimally invasive approach to fallopian tube occlusion. Hysteroscopic placement of this beaded device would induce inflammation and obliteration of the fallopian tube. The metal, unfortunately, would erode through the fallopian tube, causing infection and damage to adjacent viscera. Although this complication was recognized, marketing forces in the United States allowed it to be used long after it had been pulled in Europe. I would encourage you to watch this documentary. Although emphasizing failure rather than success, it does give insight into why patients may be skeptical accepting nascent technologies. So what can we, as an organization, do to raise the bar for the evaluation acceptance of new technologies? In some ways, I say if the FDA won't rise to the occasion to require multi-center externally monitored studies, then we as an organization should provide a platform to do so. Yes, there is risk that some progress may be slowed. Cost will be a challenge. Institutional barriers will have to be broken. I think it is important to let our egos down and work as collaborative groups, as opposed to lone pioneers. I have been guilty of this in the past. This is a big ask. It won't happen overnight. The AES, as an organization, is ideally suited to lead these challenges. Our patients will reap the benefits. The AES is a great organization. We have matured as the pinnacle of clinical investigation with service to our members and to our patients. I am looking forward to the challenges ahead. It has been an honor to serve as your president, and I thank you for your attention.